another story, something to get off my chest.
Hello and welcome to another Piper Pod. Today we're going to continue the pharmacology theme and we're going to look at all the aspects associated with safety in medication administration. Now you may be wondering why we're focusing on a non-science based topic, as in why should we even bother talking about safety in medication. And we all know we give medication, we follow the rights, we do the right thing, but the fact of the matter is a lot of us, and by us I mean clinicians, we're not statistically safe with medications, and we tend to have a opinion on medications that they're not as bad as probably we should. So medications, there's no such thing as a safe medication, as I alluded to in the first presentation in pharmacology. And the fact of the matter is hospital visits are increasing every year. So in Australia, 140,000 presentations to the larger hospitals each year is the average. Now with that, within hospitals, of the recorded medication errors, it's a medication error 1 in 10. So every 10 medications that are given, one of them is an error. And that's just the recorded ones. And we know that there are a lot of medications that are given that aren't recorded. Now, on top of that, there's about 2 million each year of adverse drug reactions to patients that could have been avoided had the right medication or the right due diligence been done. And $380 million is wasted every single year just from medication errors. So medication errors occur all the time, and as clinicians, we have a duty of care to do better. Okay? The fact of the matter is at the moment we're not, so we need to focus on medication safety. So this presentation will just bring up a few points of how to keep yourself, particularly military clinicians, safe whilst giving medication. So back in 70s through to the 90s, medication use was at an all-time high. So antibiotics were getting really popular, and pretty much every time you had a problem, medication was given to it. Now as a result, obviously the overuse of antibiotic has been well documented. This causes resistant strain, the need for more antibiotics, more high-risk antibiotics, poly antibiotics being used, and this is the same with all medications. So Australia essentially just established a agency and challenged them to come up with a national medication policy framework. So in the year 2000, the national medication policy was created, and in 2002 it launched its strategies, and its strategies included the quality use of medication, which is pretty much where we as the clinicians fit in to the whole thing, because this is all about how to actually source all the medications as well. So since 2002 we have been governed to follow the quality use of medication principles that are found within the national medication policy itself. Now, the principles that come out of the quality use of medication aren't too complicated, but just to break them down, it's all got to do with judiciousness, appropriateness, and safe and effectiveness. So when we use the term judiciousness, which I hate that word, in case you haven't noticed, it's really hard to say. It's all about selecting the correct medication and deciding whether or not we need to use medication. Now, obviously this is more focused at the prescribers, but being med techs and in the military, we'd be put in a unique position that whilst we're not prescribing, we are dispensing and administering medications based on remote protocols and vicarious care of medical officers. So with that, it really does come into play. So what it means by selecting is not selecting only the best drug for the condition, that comes under more appropriateness. It's deciding whether or not drugs are needed. And is there something else out there that can be used in order to solve the problem? So does everybody need pain relief for simple pain? Does everyone need throat lozenges when their throat's a little bit sore? Things like that. So deciding what patients actually need the medication and not just giving medication out and treating healthcare as what's that? You said a word. I have an anti-word for that. Here's a medication. So that's what it comes down to. And when we look at appropriateness, it's more looking at, are we giving, if you choose to give a drug, is that drug the best drug for our patient? So is it appropriate for them with their level of understanding in the environment that they're in? Can they continue to take the drug correctly? And we'll talk about how patients need to take the drug correctly and that sort of thing later on, but it falls under the appropriateness of the medications in which you choose. And the last one, safe and effectiveness, well, that obviously is all about us. Wherever we work, in the field, in the research space, in the hospitals, on ambulance placements, it's all about giving the medication, following the rules of administration and the rules of drawing up, dispensing, and recording the information. That's what the principles of safe and effectiveness falls under. Now, in regards to all the rules that are out there, each policy or each hospital organisation, including defence, will create their own policies associated with the use, the procurement, dispensary and administration of medications. So we all know ASI Chapter 9, Part 8 Chapter 9 I think, or Chapter 12 sorry, which is all about our authority to carry medication. Well, a lot of the information or the policies that are written by different organisations come from this National Safety and Quality Health Services. So this is Australia's answer to govern the quality of health that is given throughout Australia. Now there's 8 standards within there, and those standards range from the use of blood management, communication, preventative health, partnering with patients, what else there, how we clinically govern, recognise acute deterioration, so how high patients that we want to take care of, and standard 4 is all about medication safety. And the standard itself can be broken up into 4 big criteria. So clinical governance and quality improvement to support medication management is all about how we acquire drugs on a big scale. So how we look at getting the drugs in, how we have to store them correctly and safely, what manufacturers we use, how we go about prescribing and dispensing them. As far as administration goes, there is a little bit on administration monitoring the effects of the medicine within that particular criteria, but a lot of them will be focused down later on. So 4.4 is mostly about the administration. Now when it comes to documentation of patient information, this is all about how we write and get good records of medication history, adverse drug reaction history, and getting a good, robust and accessible database in which that information can be shared around. Criteria 4 is continuation of medication management, and that is all about how we inform the patient. So how is the patient getting information about the drugs in which they have been given? The last one is medication management processes, which looks at the way in which organisations actually give medication and put in safeguards for looking after the storage, the recording of S8s, and the monitoring of high-risk medication. So that's any policy you've ever written or read that's coming to do with medication has to fall in line with standard 4 medication safety. Just so you know, if you want to go right to the source, then you can look up the National Safety and Quality Health Services, and you can read those actions 1 through 15 if you wish. So moving down from high-end policy and stuff that you probably don't care about, or you don't necessarily have to know, but what you do have to know is local policy and what your roles and responsibility are. So the biggest role you play in patient care is making sure that the medications that are given to the patient is given with clinical analysis put in place. So the three areas that you play the role in is you need to ensure that patient adherence can be achieved. Now, what patient adherence means is the patient able, cognitively and physically able, to follow the requirements of that medication? So are they able to take it at the correct intervals, not do the things they're not supposed to do, like drinking, eat without food, lie down afterwards, things like that? Are they able to administer it themselves? Okay, so that's what patient adherence. You need to make sure it's not just giving the drug and making sure they're physically able to take it, but are they able to follow the parameters in which that medication must be given? And on that, you are the one responsible for educating them on that medication. Make sure they have a full understanding of what is required, how to manage simple side effects, how to go through storage and self-administration, that sort of thing. So that is your role. It's also very important that you tell them about any red flags. So if you notice any of these symptoms, then you need to go in. Now, if the patient has concerns, or if the patient doesn't want to, or in a lot of cases in our line of work, if the patient shouldn't be in the environment that they're in, that it is absolutely your responsibility to be the advocate for them. So a classic one that comes up is if someone has open hemorrhoids in a field environment, we could give them medication, but that's only part of the problem. Part of your patient advocacy role would be removing them from that environment purely for a hygiene-based reason. Okay, now in order to help you make all these decisions and have all this understanding, you need to know things. Okay, you have to have an understanding of the job that you're doing. So when you have drugs that you are carrying in the intake box or anything that you've been authorized to carry, then you need to know about that drug, how to administer it correctly, how it needs to be stored, the pharmacokinetics, the pharmacodynamics of the drug, so you're looking at interactions. You need to have a base understanding of anatomy physiology to understand how it all works. And you must, as boring as it may sound, have an understanding of your legal and ethical responsibilities towards the patient and the use of medication. Bottom line is, whenever we make a decision to use a medication or make a decision about patient care, we need to go through a clinical decision-making process. Now, you don't have to use ADPI, okay, but it's just an acronym that helps illustrate the importance of what you need to do. So assessment, and full assessment is needed. So you need to approach a patient care, especially associated with medication, from a holistic standpoint. It's not just cause and effect. Find the problem, give the drug. You need to look at it from a big standpoint. Ascertain what medication they're on, if they have any adverse effects in the past, their level of adherence, things like that. When we move down to diagnosis, it's not just about the disorder that they have or the pathophysiology. It can also be a diagnosis in non-adherence or something like that. So inability to take a drug. Therefore your diagnosis changed, and we need to look at that with the assessment, come up with a plan, and then you do the usual. The implementation of the plan associated with the education, and then evaluate it if it works. If it doesn't work, then you add that information back to the assessment and you go through the process again. So it may seem like a long, drawn out process, but this is the clinical decision making that needs to be done in order to reduce the amount of patient errors. So every time you're approached with a new patient, a new drug, a new situation, take the time to go through the clinical decision making process itself. Okay, so speaking of medication errors, let's break down where they actually come from. So most of them comes from the ordering side of the house. Now it is easy to dismiss that as, oh well, that's the doctor's problem because they're the ones ordering. But just remember that now you are the one ordering drugs in the absence of a doctor. And if doctors are making 49% of the medication errors just in ordering, then you can most definitely make that same mistake by giving the wrong drug itself. Okay, so the wrong drug for the condition, just getting them slightly mixed up, and then ordering the wrong one, or giving the wrong one thinking it's something else. Okay, so that can definitely happen. 26% of administration, that is deeply within the realms of what we do. Every medication that we give is all about the administration. So this is the wrong dose, the wrong patient, the wrong route, the wrong time, all that sort of stuff. All falls under the administration. Transcribing is about our documentation and how well we communicate the medications that we are giving or have given in our case. So that's where that area come in. And then the dispensary. So that whoever's dispensing it, usually the pharmacist, reading the ordering and then giving the wrong drug. Or most of the time the correct drug, but a different strength concentration that is in the wrong box and that sort of thing. So it goes through all levels of choosing the drug, getting the drug out, and then administering it. There's errors across the board. And when you are working as an intake medic, it is you that is taking care of all of those aspects. Okay, so it's not just important when working in a hospital, even though that does play a huge role, and that's where these statistics have come from. It comes from you working as a remote practice medical technician out there all by yourself as well. So, the reason they happen is distraction. You've got other things on your mind, you don't take the time to think, so you have more than one patient, you get them mixed up, so you go from there. If you're not so familiar with the medication, not familiar with the environment or the loading or anything like that, you can make mistakes. You can look at medication with similar name or packaging. That's why I mentioned in the first one that it's always important to use the generic name, not the brand name. Generic name, so it reduces the risk of having medication errors from similar names. Now, patients that have adverse effects to medication, you need to ask. And if you find out that someone has an adverse effect, that needs to be documented very well. So you need to look in the JEDI, you need to ask the person specifically if they have any adverse effects to this drug and then to anything else. Mistakes are very often made when a therapeutic level needs to be monitored. So blood tests aren't taken before a medication is given, and therefore it's a medication error because the dose is dictated by the levels that is given on the blood. So to save time, people will just give the drug, or lack of knowledge, they just give the drug, and then they end up giving too much or not enough, and it's not effective. Giving it incorrectly, so mixing it wrong, especially IV drugs. If you're administering something that needs to be mixed a certain way, then not knowing that, or not knowing what drugs interact with other drugs, and then just giving it because it's been prescribed. Huge case of medication errors. And then not following procedures because you're too busy, not enough knowledge, or most of the time it is just pure arrogance that you think that you're above the procedures. You don't have to do the 5 rights. You don't have to get this double checked. That takes extra work. I'm a competent individual, and then mistakes happen. So a lot of the statistics that are out there come from people that give drugs every single day. So you could argue that complacency is a problem, but if they establish good work practice and follow procedures that have been put in place not only because they have to be, but because statistically they've been known to reduce medication errors, and not having the arrogance that you are better or know more, therefore don't need to follow the procedure, then medication errors should be reduced. So as a minimum, and this is what's written in literature, because these rights to medication, I will 100% admit, it has gotten out of control. Absolutely out of control. It is written now up to 16 rights of administration. So mostly 10, anywhere between 6 and 10 to 12, 14, 7. But the highest number I've ever seen is 16 rights of administration. And then there's an additional 6 rights for the nurse's rights to question medication and things like that. So I don't blame anyone that just thinks that it's just fucking insane, the amount of rights that are coming out. But as an absolute minimum is the 5 rights. They've been tried and tested across lots of different workplaces and lots of different environments, and the 5 rights is the absolute minimum of what you should do each time you give a medication. And on top of that, obviously we have the correct documentation. So that's the only additional right, if you will. So the right drug, dose, time, route, and person is the rights. And on that, when we're looking at the drug, we need to check that drug 3 times, because it's very easy to have a quick slip at the drug, look at the box, then we need to look at the medication in the box, what we put into the dispensary, and then what we physically put back into the cupboard. So just looking at the drug and taking that time will reduce the associated risks of medication errors. So that's your 5 rights, and that is the minimum 5 rights that you'll see in literature. If you want to do additional to that, knock yourself out. But it is an expectation of all workplaces with medication that those 5 are done at an absolute minimum. Okay, now let's talk specifically how in the world that we work in, the worlds that we move into, how do we avoid the drug errors? So it always says that we need to identify the right patients, and in some circumstances that's simple, because you've done a consult on that person and you're thinking of giving that person drug. So obviously it doesn't apply in that situation. But when you have been given a drug order and you're working in hospitals, especially the way we do, which is intermittently, you need to 100% assure that that is the right patient. Now on top of that, if you're ever involved in a multi-casualty event as well, you may find yourself in a position that you're jumping between beds, okay, and you're helping out different areas. Therefore you need to know that if a drug order has been given, you need to go away and draw it up and draw it up for administration, and you need to make sure it comes back to the right person, and on that have the right drug with the right dose as well. So that's what we need to do. So there's the environments where right patients often gets mixed up. Now the correct drug and dose is, believe it or not, quite easy to mess up, okay, especially when you start talking about complex mixes of drugs and the way they need to be drawn up to be administered. You need to really ensure that those drugs are the correct ones and they're given at the correct doses. So with that, always use your handbooks. Always have a look at the handbooks, especially the therapeutic guide to IV medications of how to draw it up. Always refer back to that. Okay, you can't keep all this information in your head, and if you try to, it's very easy to mix up the information. So just have the handbooks and then check them. When you're outfield, have databases on your phone associated with medication so you can look up this information. Always maintain clear communication. So if a drug has been ordered, say it back to them, get it double checked, and then administer the medication and let people know that the medication has been administered, especially in a resus situation. Double checks are mandated for high alert drugs that will go through, but it's also mandated in any pediatric wards. All drugs that are given must be double checked. And in environments like resus bay, acute care, things like that, it is always a good idea when pushing IV medications that we have that clear loop, therefore double check of administration before they're going in. Talk to your patient about them. Ask them about side effects. Take the time while you're not seeing patients or doing anything to educate yourself on medication. If you read an order or someone says something that doesn't seem right, have the balls to question it. Okay, people don't know everything regardless of their status, and people make mistakes. It's human. So always clarify. If they get upset at you, then let them get upset. Who cares? At least you've clarified, because if you don't, then you're that final chain that makes the error, and therefore you're part of the problem. Now, in regards to correctly labeling medications, it's a requirement that every single IV medication gets labelled correctly. So if you are drawing up an IV medication and that medication is going to leave your hands before it's administered to the patient, then it must be labelled. So if you're bedside and you're drawing up a drug and you push it straight into the patient, then there's no need to label it. But any circumstance outside of that, like you are hanging a bag with something added to it, you are giving out syringes with different medications, they must be labelled correctly. So we need the patient's details, we need the drug, the detail of the drug, concentration per mil, and total concentration written in there, and that's basically it. It just needs to be labelled. So look at the policy of where you're working, look at the tags that they have, and if they don't have correct tags for medication labelling, then be part of the process to try to find one. Okay, so that's the rules and tips to avoid errors in medication. Now, when we talk about high-risk meds, there are a bunch that have been listed. So these meds you need to have double check all the time. Now, in certain hospitals or different work environments, other drugs may be included in this, or additional to this list, but this is the list of things that always must be checked by two people. So any anti-infective, which means antibiotics, antiviral, antifungals, must be checked by a second person. Now I know you're thinking, yeah, antifungals, they need to be checked by a second person when administered. The reason for that is there are a lot of people allergic to anti-infective agents. So it mostly applies when an order has been written. You need to make sure that it is that particular drug at that strength, therefore you get it double checked. Any electrolyte, especially potassium, must be checked because the wrong doses can kill people very quickly. Same true as insulin. If you're working in a hospital and insulin has been ordered and you are not familiar with insulin and you haven't given it before, you don't quite understand units instead of mils, then stop and ask someone who gives it regularly to walk you through it and get it double checked. If you give too much insulin, you'll kill someone very easily. Narcotics need to be double checked. Sure, they're dangerous, but they're also drugs of addiction. Chemotherapeutic agent, mostly IV, but you can get oral medications, need to be checked. Again, very, very dangerous drugs to give, and a lot of the times in Australia you need to be qualified in chemotherapeutic agents before you're able to give them. That's a policy for a lot of hospitals. And any anticoagulants, especially heparin, usually given as infusion or stat dose, needs to be double checked before administered. Now, when you're getting this double check done, a lot of people fall into the habit, if you will, of going, here's 100 units of insulin as you show them the syringe, and then the person absently glances over and goes, yep, that's what it is. But that's not how you should do it. You should always show them the medication, show them the syringe, and get them to tell you what it is. That way, that is two people actually checking it to see if you put the right strength in the syringe, it's labelled correctly if it needs to be, and then you're giving the correct drug. So that's what double checking is all about. Now, these high-risk meds are there for a reason. So regardless of your opinion of whether or not they should be checked or not, there is an associated high risk. So ask yourself, is it worth the risk not getting them double checked? Okay, is it worth the risk? The answer should always be no, of course. So let's say you do make a mistake, because that happens all the time. People make mistakes. The big thing that you need to do is not cover it up. You've stuffed up. A patient's been given something they shouldn't have been given. You need to make people aware. You need to realise that it happens regularly based on the statistics, and you need to go and tell the supervisor to get advice. From there, whoever's treating that individual needs to be known. So the doctor needs to be notified of that occurring. Now, in the event that you've given the wrong dose outfield and you made a medication error, then you need to call the doc and you need to tell them what happened. You go from there. You need to obviously stay with the patient and look for signs of adverse effects, and you need to document as a minimum in the patient records and medication chart this error has occurred, and then in certain organisations there'll be medication incident reporting if required, and that organisation will let you know. Stay with the patient until you get full instruction on what needs to happen, and all the identification processes have been done. Okay, so all the records have been made, you've let everyone know, and then you move on from there. A lot of the times, most medication errors don't end up in severe adverse effects, but it still needs to be notated that it was done. Okay? So then you can start collecting trends, see if there's something in the workplace that is causing medication errors as opposed to an individual. And also for yourself, to identify it, own up to it. Don't try to compartmentalize it as something that is little, because if it continues and you keep making the errors and don't recognize them, then you're going to lead yourself up to more quantified risks and then greater negative effects. So just identify the errors if they ever occur. Okay, that's it. Safety medication in a nutshell. Now from here, if you want to go on and continue a little bit of training on quality use of medication, then the NPS Medicine Wise Learning website has a course that you can do. Now it's just a couple of videos and then a test on it, but it's a way of testing your understanding of the concepts that we've gone through. It also acts as CPD if you need that, which no one really does. But if you wanted to go on and have a look at it, and if you're thinking of moving into working in hospitals that give a lot of medication, then it's a good idea, especially if you've been out of it for a while, to do courses like these ones in order to refresh yourself on expectations for medication safety. But until next time, take care.